Hi, I'm Dr. Trudy Gores, and today we're going to be talking about gastroesophageal reflux disease, or GERD, also known as heartburn, and also hiatal hernias, their diagnosis, their treatment with surgery. In people who have heartburn or gastroesophageal reflux disease, that can be manifested in many different ways. Some people simply have chest pain or that burning feeling. Some people have food getting stuck as it's going down. Some people belch or feel like they have bloating a lot, and some people simply have nausea. So part of the workup that we'll talk about today is to determine what your symptoms are due to and how we can correct that. In most people, this is normal anatomy. Your esophagus is supposed to pass through your chest and then pass through this hole in your diaphragm called the hiatus. Then that's where it's supposed to join up with your stomach. In some people who have hiatal hernias, that junction has moved above the diaphragm and into their chest, and a picture of a small hiatal hernia is shown there. As you can see, people who have a hiatal hernia have their reflux valve constantly open, precluding them from having closure of that and having a competent reflux valve. Therefore, food and fluid can come through and into their stomach, but it also is a two-way street and can actually reflux back into their esophagus, causing symptoms. In other people who have heartburn, they don't have a hiatal hernia. Their anatomy is normal, but that valve is simply weak, and therefore, again, fluid that's sitting in their stomach and food can also reflux back into their esophagus, causing discomfort, burning, and sometimes actually have respiratory problems as well. The problems with having chronic reflux or heartburn can be seen in these three pictures. Your esophagus was made to hold acid. The lining of such was made for that. Your esophagus, however, is not. So having constant reflux into your esophagus can cause inflammation, ulcerations, precancerous changes called Barrett's esophagus, and also stricturing or scar tissue formation because your body is trying to protect itself and actually make a new reflux valve. In individuals who come to the office, some of this testing will already have been done by a gastroenterologist or possibly your primary care doctor. The first study that we like to talk about is a barium swallow or an upper GI. That's simply an x-ray where you're drinking contrast and a video is made of that contrast passing through your upper GI tract, your esophagus, and your stomach in order to determine what your anatomy is, how that contrast passes through, and if there are any abnormalities. During that test, usually you'll be laid down in several different positions to see if you actually do have reflux. Secondly, an endoscopy or an upper endoscopy or an EGD as sometimes they're called. This is where a camera is put down with some light sedation down into your esophagus and into your stomach to see the linings of your esophagus and stomach, but also to be able to take biopsies of tissue. The third test that's noted here is called a pH monitoring test, or a Bravo test is sometimes what it will be called. During this test, a small monitor, about the size of the end of my pen, is actually placed in the esophagus just above the stomach. And what that monitor does is for 2 days, it will communicate to a tiny wireless packet that you'll wear on your belt, and it will actually sample the esophagus in the environment to see how much acid is actually coming up for 2 different days. Also on that little wireless monitor, you'll actually have areas where you can push buttons if you're having heartburn, if you're having chest pain, or if you're feeling like you're refluxing. So again, we can correlate your symptoms with what's actually happening in your esophagus. The next couple pages talk about different medications, ways that you can change your diet in order to treat heartburn. But in terms of surgical options, after all those have been exhausted or they're getting too expensive or you're having side effects from medications, we want to talk about surgery. The options for heartburn surgery or hiatal hernia surgery are twofold at this point in time. The first one is a classic Nissen fundoplication, and a Nissen fundoplication has been done laparoscopically since the 1990s. And this is a laparoscopic procedure where you have 5 small incisions on the abdomen above the umbilicus. The goals of this surgery are to restore your anatomy, and in order to do that, we laparoscopically release the stomach from scar tissue that is formed up in the chest to the linings around the heart and the linings around the lungs, and we get your entire stomach and a portion of your esophagus below your diaphragm. After we have done that, we'll actually close the hiatus with stitches and sometimes a small piece of mesh that is degradable over 6 months. Once the hole is closed in your diaphragm, then we need to make you a new reflux valve. And to make you a new reflux valve, we'll take this portion of your stomach and wrap it around the very distal part of your esophagus, as you can see here. And depending on the strength or the weakness of your esophagus, we'll either make you a full wrap or a 360-degree fundoplication, or if you have a weak esophagus that has weakened over time, we'll make you a more gentle wrap or a partial wrap so that your esophagus can still empty of food, but you still have a good reflux valve to keep fluid and food from coming back up into your esophagus. Immediately post-op, you will be in the hospital for 2 nights, and that's in order to allow for us to get another x-ray on the first post-operative day in order to make sure that the contrast is passing through your esophagus and your stomach without too much delay, that your anatomy is as it's supposed to be, your stomach is below your diaphragm, and there's no leaks. If this is the case, we'll start you on a diet consisting of jello and juice and popsicles and very thin fluids. If you do okay with this, we move you on to what we call the full liquid diet: yogurt, protein shakes, cream soups. If you do okay with this, we'll start you back on some of your home medications and some oral pain medications, and then get you on what's called the level 1 diet. We'll go over the level 1 diet in the office with you, but the level 1 diet is the first level that you'll go home on for 2 weeks. I'll have you come back here to the office after 2 weeks so we can make sure that food is passing through okay, you're not having too much nausea, and you're getting back to normal activities. I'll see you again in the office at 6 weeks post-op to make sure that you're going through levels 2 and 3 and finally level 4 of the diet, which is usually regular food. Activity is restricted after this surgery because we are closing that hole in your diaphragm. I don't want you to be going home and lifting anything that you have to strain to lift or that is usually in general greater than 10 pounds. A gallon of milk weighs about 8 pounds. We do want you to be active after surgery so that to avoid such complications as blood clots in your legs, pneumonia developing in your lungs, and the more active you are, the better circulation you have and the better you're going to heal. The second alternative for heartburn surgery is a new development. In the last 5 years, we've had studies show us that instead of doing wraps of the stomach around the esophagus, that we're actually able to augment or just support your weak reflux valve in order to allow for better integrity and less reflux of fluid and food up into your esophagus. The LINX, made by Torax, is shown here. And as you can see, if you have a weak valve with a small hiatal hernia, you're a candidate for this procedure. How this procedure is performed is very similar to a Nissen fundoplication in that it's a laparoscopic procedure. There are 5 small incisions. It is general anesthesia, but instead of doing any kind of wrap or changing your anatomy greatly, we're simply measuring your esophagus for an appropriately sized titanium bead bracelet. There are magnets inside of the beads, and in order to allow for reflux treatment, the bracelet will sit at a pressure of 30 millimeters of mercury. If your preoperative esophageal pressure testing shows that your esophagus is able to generate more than 30 millimeters of mercury, we're able to implant the bracelet. Food is able to pass through as your esophagus is pushing, but once the food has passed, the bracelet resets and keeps acid and food and fluid inside your stomach, and it keeps that food from refluxing into your esophagus and you having heartburn. The difference between these 2 procedures is that instead of having 1, 2, and 3 levels of diet post-op, we want you eating basically normally immediately post-op in order to exercise that bracelet and keeping that scar tissue from keeping food from going down. The lifting restriction is also different because we're not changing your anatomy and doing any kind of wrapping of the esophagus. And usually people are quite happy with this. The studies have shown that after 5 years, most people are off of their antacids and actually not feeling any kind of heartburn or any kind of food sticking as it's going down. So this is a new development in reflux surgery, and in the office we'll be able to talk about what surgery is right for you.